Welcome back, welcome back, welcome back to science. All right, so today we're talking about blood pressure. This is something that has a major complication for really life of anybody at any age. The older you are, the more it becomes a problem in the sense of people with high blood pressure oftentimes have life-threatening events as a result of their pressure. And so I want to really dissect out what blood pressure is, what causes high blood pressure, and ultimately the changes that can be made to help keep healthier vessels and even a healthier heart, leading to higher life expectancy. So, blood pressure is literally the amount of pressure, the hydrostatic pressure that is there in the system inside the blood. So, if you go inside of a blood vessel and measure the pressure that's there, that is the blood pressure. The blood has to move through the body to take care of all of its different organs and muscles and different things that are there. It is so key that it gets to those things, that it takes care of everything, that any kind of thing that gets in the way of this or decreases or increases could have potentially catastrophic effects. So let's really identify what blood pressure is. When your right ventricles contract, when your left ventricles contract, and it's ultimately left ventricular that is the biggest part, you're going to have a massive surge of pressure going into your blood vessel. So when the ventricles relax, you're going to have that decrease in the blood pressure. The arterial systolic pressure, and you may have heard of this as just the systolic pressure. And whenever you're taking a blood pressure of anybody, this is the top number. So the systolic number. The systolic is going to be that higher number. This is the maximum pressure that is reached during ventricular contraction. All right, so back to my hose analogy, like a water hose. If you put, let's say you block it off. So you've blocked it off. Blood flow is going to be moving towards that blockage. It cannot get through because it's blocked off. At a certain point, the pressure of squeezing this shut is overcome by the amount of pressure in the vessel. So if this is squeezed really, really tight, let's say it's 200 millimeters of mercury squeezed, most people are not going to have blood flow flowing through there. And the blood is going towards, but not going through that area. As you reduce the pressure on this, at a certain point, the pressure that is upstream from that is going to be enough to allow for blood to go through this. So when blood is actually going through that opening, there's enough pressure for it to move through. That is going to generate your systolic pressure. When you think of using your blood pressure cuff called a sphygmomanometer, whenever you squeeze, you pump it up and squeeze the blood vessel shut, and you start to relax that dial, the pressure falls, and then the first number you hear, that's the systolic number. And you're going to keep listening as the blood is going to be moving through, and you can actually hear the Korsakoff sounds as though the blood is flowing through the vessels. At a certain point, it's relaxed enough that you don't hear that. That is the minimum pressure remaining during the ventricular contraction. That's going to be the lower number on your blood pressure. So the top number is the systolic number. The bottom number is diastolic number. When I was in high school taking anatomy for my very first time, I always remembered it as San Diego. The S over the D helped me remember it. Eventually, I learned that it was systolic over diastolic, but San Diego helped a little bit back when I was just a rookie. All right. So pulse pressure is going to be the systolic minus the diastolic. So if you know your own blood pressure, I want you to go through some of these examples just on your own. I don't need to know your blood pressure. You keep that to yourself. But start working with some of these numbers so you can learn about you. So your pulse pressure. The textbook gives an example of somebody with a blood pressure of 120 over 80. 120 is systolic, Diastolic is 80, so 120 minus 80 is going to give you that 40. So the pulse pressure is 40. Now, another thing that needs to be done is to find the mean arterial pressure. The mean arterial pressure refers to the average pressure that's going to be in the arterial system, your arteries. So this is going to be the big force that's driving your blood through your system. So this is post-heart, after it's left the ventricles. And you can generate this number by taking your diastolic pressure. Our book gives an 80 as the number. And you're going to multiply it by 1/3 of the pulse pressure. So 80 plus 1/3 of our 40 is going to give us a total of 93.32. That is the mean arterial pressure for this individual. So do your own. Take a moment and find out your mean arterial pressure. Find out your pulse pressure. And if you don't know these, then let's say that you have somebody who has a blood pressure of, they have hypertension, they have 140 over 110. So have fun with a little bit of the math or practice a little bit just to know that you can derive the pulse pressure. You can also derive the mean arterial pressure. All right. So once again, the sphygmomanometer is the thing that's going to be it's the cuff whenever you're calling the blood pressure cuff. It's not the stethoscope, it's the cuff. And it's going to measure things in millimeters of mercury. Pressurized systems are going to do that. And so you're going to see anything under pressure with an mmHg there. So that's referring to the millimeters of mercury. Here's the sphygmomanometer. I love this dated sphygmomanometer. This thing looks 1,000 years old. Notice that the blood pressure is going to be highest as it is closest to the heart. So just as it leaves the left ventricle, you're going to have highest blood pressure there. So this is the 120 over 80. And then as you get farther away, larger arteries, smaller arteries, arterioles, and then our capillary bed. And then we don't really have much pressure at all in our capillary beds. As we looked earlier in a subsection, we saw about 16 millimeters of mercury in our venules as we were looking at a problem in a previous section. These are areas where you can take the mean arterial pulse to measure pulse of an individual. A really common one is checking in your carotid artery. So if you're taking your fingers, I like using my middle finger and ring finger to do this. And you're going to go here. So you can feel both sides and move around a little bit and do this on yourself. And get that pulse. You can start to feel it. The reason I don't like to use the pointer finger is you have a lot of vascularization to this, and sometimes you can feel your own pulse in this. I know nurses that use the pointer and do just fine. I just know that in the teaching side of it, that these two fingers are used more, the middle and ring, than the pointer. If you're going brachial, not brachial, but the radial or pulse, I see a lot of people using the pointer finger. It's usually not an issue. With a living patient, feel free to use this. With a patient that you're not sure that's living or not, you may want to use the middle two. Here's why. You have a non-responsive patient on the ground. You go check for a pulse, and you check like, okay, I can feel a pulse. All right, we're all right. And reality is, it was the pulse of your pointer finger, your own pulse, and they were dead the whole time, and you should have been doing compressions. Where if you're using these two, you don't have as much blood flow to those, at least to the point where you don't feel it. And so if I'm checking a pulse of somebody that's non-responsive, I'm using these two. And I like to use this on carotid artery, pointer usually on the radial artery that's there. And so you can change those. And I ask you to explore this, feel your own carotid artery pulse, and find somebody you love or that loves you and is willing to let you do that to check their pulse, just to feel. And typically when you're checking a pulse, you're going to do it for 15 seconds and you're going to multiply it by 4 to get their heart rate for a minute. All right, these things are going to influence the arterial blood pressure. So we're going to focus on each one of these in the near future. All right, so let's talk about stroke volume. Stroke volume is the amount of blood that leaves the heart and it's going to and enter the arteries from ventricular contraction. An average number is roughly 70 millimeters, milliliters per beat. And you think, okay, so that's the amount of liquid that in a heartbeat squeezes from the left ventricle out. So if you have 70 milliliters that's leaving, you can do like how much blood do you send out of your heart in a minute? Well, you can find your pulse rate and multiply that. So I'm going to try to take mine in real time right now. Probably could have done this a little better. Give me a second. I'm committed to it. All right, we'll do it later. All right, so cardiac output is going to be the stroke volume, the amount that it's leaving your heart, times your heart rate. So in this scenario, we have 70 milliliters leaving the heart. We have 72 beats. So that's roughly 5,000 milliliters that's leaving per minute. So the increased in stroke volume or heart rate is going to cause an increase in stroke volume, cardiac output. So if you change any of these two numbers by higher stroke volume, so let's say that your heart is bigger and pumping out more blood, then you're going to have a larger cardiac output. Or let's say that you're exercising and you've increased your heart rate to 180 beats per minute because you're going through rigorous exercise. That would also, so take your 70 that may not change and times 180, and you're going to get a significant amount of blood movement, so a much larger cardiac output. So cardiac output is going to be a measured metric of stroke volume times your heart rate. Blood volume. So how much blood do you have? On average, 5 liters. Guys have typically 5 to 6 liters, which is about a gallon and a half, and girls have 4 to 5 liters. So as an average for adult, we'll just say 5. It's roughly 8% of your body weight. And so you know your body weight. You can calculate that up if you'd like. So blood pressure is going to be directly proportional to your blood volume. If you have lower blood volume, you're going to have a lower blood pressure. Let's say that you have a laceration, you're bleeding out, you're hemorrhaging. Yeah, you're going to have a low blood pressure. And so you see this oftentimes in an ER whenever you have a patient rolling in with a severe trauma and you're checking their blood pressure and like, it's low. What? You would think in the stress they're bleeding. The pressure, it's an open system now instead of a closed system. And so, of course, you're going to have lower pressure. So decreased blood volume is going to be due to things like hemorrhage. This is going to have a decrease in blood pressure. All right. Another contributing thing to blood pressure is peripheral resistance. Peripheral resistance sounds more like a physics term, and really, if you're looking at blood vessel, the flow of things, there's a certain amount of physics that you're looking into. And physics is math and science, ultimately. Anything that's blocking a vessel is going to cause resistance. Maybe you're going to cause a vessel to be smaller. That's going to be a peripheral resistance. The only way that you can have the same amount of flow to an area getting a target amount of fluid and there is a blockage or smaller vessel is to increase that pressure so it can get past that blockage. And so peripheral resistance is going to contribute to increased blood pressure. So when blood is pumped out of the ventricles, arteries swell. And this is like a rubber band effect. And I think this is so neat. So it's not, our arteries aren't just like a tube, like a piece of plumbing, a pipe where blood is just flowing through it. Yeah, it's going to flow through it. But as the major pressure here of that ventricular contraction going to the aorta, this vessel is going to swell. And it's going to swell and help alleviate a little bit of that pressure. And since the pressure is higher here than here, it's going to go from high pressure to low pressure. So blood flow is naturally going to go from here to this area. So this is going to help push blood downstream towards the capillary bed where there's lower pressure, because remember, on the venule side of things, that we're looking at roughly 16 millimeters of mercury. And here at that capillary bed, we're roughly at 35 millimeters of mercury, meaning that we're moving from here to here. And so that blood flow going from higher towards the heart, as we get towards the arteries, it's lower. Towards the arterioles, it's lower. Towards the capillary beds, it's lower. And it's pretty low at the venule side of things. And so as you looked at this image here, this is showing that change of pressure as we've had that pressure change throughout the system, essentially being dissipated, and the ability of these vessels to swell like a rubber band and move right back. Their elasticity. Now, the fluid component of blood itself also is going to help blood flow or change its ability to flow. The greater viscosity, the greater the resistance to flow. So if something is going to be really, really viscous, really thick, if you will, blood's not going to flow as well. And this is one of the threats of why blood doping, people using erythropoietin to generate more red blood cells, so the person has a lot of blood cells, this is going to increase the viscosity of the blood, causing blood to not flow as easy. And so you're going to be more prone to different things like embolisms, clots, clogs. So viscosity affects the flowability, if you will, of a vessel. A fix of this is if you can make the liquid a thinner liquid. If you're comparing um, molasses to oil, oil is going to flow much easier to slow molasses. Molasses has a higher viscosity than oil. You can change the viscosity of your blood. We know that we have natural ways of doing this, like our basophils releasing heparin, which is going to cause our blood to be thinner. But there's also now medications. I say now like it's recent. It's not really recent. And you can take blood thinners like heparin. There's many other on the market, but it changes the viscosity of the blood to cause where there is an occlusion of a partially blocked vessel. Instead of having to raise the pressure really high to get it through, you can just make the liquid thin, and the liquid will flow through easier under lower pressure. And this removes some of the threats of things like aneurysms or TIAs or CVAs, um, these major strokes that could occur because of the high blood pressure or myocardial infarctions that may be an effect of blown vessels. All right, so we can change viscosity both medically and also somewhat ourselves, though having our basophils release heparin to treat our blood pressure is not necessarily a way that is common, the way that works. So any factor that's going to alter the concentration of blood cells or plasma is going to alter the viscosity. Anemia. You have low concentration of blood cells, you have lower blood viscosity, the person has lower blood pressure as a result. All right, things that are contributing to the control of blood pressure. Blood pressure is going to be the product of cardiac output and peripheral resistance. We know the cardiac output, we looked at stroke volume a minute ago, and we looked at the amount of flow that happens per minute with heart rate. So that's cardiac output. So cardiac output, CO, is its own equation. And peripheral resistance is basically saying if we have any blockages in any of the vessels, that's going to be a potential problem for cardiac output. So the blood pressure is going to have those two things, cardiac output and peripheral resistance. If it's flowing into really wide vessels, blood pressure is going to be low. If it's flowing into constricted vessels or partially occluded vessels, then it's going to be high. So cardiac output is the product of heart rate and stroke volume. Stroke volume is the difference between the end diastolic volume and the end systolic volume. End diastolic volume is going to be volume of blood in each ventricle at the end of ventricular dystole, where the end systolic volume is going to be the blood remaining in each ventricle at the end of ventricular systole. So, um, several mechanisms, both neurological and chemical factors, can all affect stroke volume and heart rate, meaning that this is potential to change depending on the situation we're in and those factors. Now, stroke volume, the cardiac output, is going to be depending on the venous return. If you have a low amount of blood that's ending up into your right atria and right atrium, then this preload amount can't really be what we need it to be. So the end diastolic volume is really dependent on the amount of blood that's going to there. Because as we're looking here at the end diastolic volume, this is the amount of blood in each ventricle at the end of ventricular dystole. This is relaxation. So that's the preload as it's relaxed, as it's filling. So if we're not getting a lot of blood that's going into the right atria, that's going into the right ventricle, then this preload is going to be smaller. So the higher the end diastolic volume, the greater the mechanical stretch of the ventricular myocardial cells. So the more blood that can go in, the more stretch we're going to get, the more the force that's going to drive things upstream. So if we have plenty loading, then we're going to have contraction, we're going to have the vessel expanding, and this is the concept of Frank Starling law of the heart. The end systolic volume, we have these factors that are going to be affecting it. One is the preload. Once again, systolic is going to be that contraction. We have the contractility of this. So this is the strength of contraction. Then we have the afterload. This is the force of the ventricles that has to be put on the semilunar valves to actually cause them to open. And so if that is a higher number or lower number, it could affect the amount of blood that's able actually to escape the ventricle. So cardiac output, peripheral resistance, and therefore blood pressure are regulated by the baroreceptors. Now, we talked about baroreceptors. That's going to be in the aorta, that's going to be in the carotid, and these can be cardio accelerated or cardio inhibited in a way that they're going to have a feedback that says we need more or less of this pressure as a result. Epinephrine, you also call this adrenaline, but let's just, in our class, call this epinephrine. It's going to be a hormone from the adrenal medulla, and it's going to, once again, adrenal medulla, we're talking about above the kidneys, and this is on the inner portion of that, the medulla. This is going to increase heart rate, cardiac output, and blood pressure. So if you have adrenaline rush, you're going to have a heart that's beating more, you're going to have more blood that's being pumped, and you're going to have more pressure in your vessels. Peripheral resistance is going to be derived from a changing arterial diameter. And so if you cause the blood vessels to get larger in one area, oftentimes they're going to get smaller in a different area, a contrasting an area, an antagonistic area. So as vasoconstriction reduces the arterial diameter, this increases the peripheral resistance, meaning that vessel's smaller. It's going to take more pressure to get through that vessel while it's constricted. On the other hand, if you have a really wide vessel, vasodilation, now that you've increased the vessel diameter, this is going to decrease the amount of resistance. As a result, it's going to decrease the blood pressure needed. Vasomotor center, this is going to be tied to your medulla oblongata. Once again, we're looking brainstem, just inferior below to of the pons, at the top of the spinal cord, kind of between those two areas. This is going to regulate the diameter of our arterioles. Therefore, it's managing the peripheral resistance. So by changing the sympathetic nervous system, the sympathetic innervation, the muscles in the walls of the arterioles, those smooth muscles are going to vasoconstrict or vasoconstrict or vasodilate as a result of our medulla oblongata vasomotor center. All right, hypertension. Hypertension is really common. It's around us, it's in every hospital. And matter of fact, it's probably with many people in the class. Hypertension, hyper means above. Tension is referring to your blood pressure. So this translates to high blood pressure. So this is long-lasting elevated arterial blood pressure. Causes, some people have it for no known reason. Other things that contribute, increased sodium intake. So let's say you have high blood pressure. One of the things that they're going to tell you to do is like decrease the amount of sodium in your diet. But I like salty. Do you like to live or like salty? Which one is more important to you? And usually people make the right decision. Some don't, and it's an early exit. Another thing that can cause hypertension, physiological stress, literally emotions, can stimulate the sympathetic nervous system, causing people to have hypertension under stress. People that are under stress oftentimes have CVAs or TIAs. Obesity, a major problem, and this has to do with peripheral resistance. Kidney disease, this is through the renin-angiotensin response, where your kidneys aren't exactly working like they should. This is called the silent killer because you don't necessarily see something easily from the outside. So it's not like um, you have an area that turns purple or you have whatever. Oftentimes you have late symptoms of a major thing. One of the contributing factors, and it's a type of peripheral resistance, and that is atherosclerosis. So that's plaque that's going to be forming on the inside of the wall. This may lead to coronary thrombosis or an embolism. This may lead to a cerebral thrombosis or an embolism or a hemorrhage that could be affected by a transient ischemic attack. This is a mini stroke, or a cerebral vascular accident. This is a major stroke. Rupturing of a blood vessel, and due to the rupture, you have bleeding out. Anything downstream of that broken vessel can't get its nutrients and will die. And when you have an areas of the brain die, then you're considered to be brain dead. All right, so preventative measures for hypertension. A healthy diet helps a lot. A regulating weight and a reasonable weight helps a lot. Regular exercise, it's important. As we've been seeing on the venous side of things, with regular exercise, this is going to be contributing to you sending more blood back to the heart, ending into the right atrium, which is going to send more blood that can be pushed out. So it's going to be healthier for you to this. Limiting sodium intake. So treatments. Let's say that you have hypertension and it needs to be fixed immediately. You can have sympathetic inhibitors, which is going to reduce the amount of vasoconstriction. And you can also have diuretics. Now, with venous blood flow, blood pressure decreases as blood moves from the arterial, the capillary network, and then it's going to get into the venous side of things. This is only part of the direct health of heart action. So, as you have muscle contraction, it's going to squeeze that blood. We looked at the gastrocnemia, squeezing the blood, moving it upwards, and the valves that are going to keep it. And the more that you have contractions, the more that you're going to have blood that's going to be moving from these areas, having less pooling. So muscle contraction is going to squeeze bloods. And by I say muscle contraction, it's not you just go flex for a while and get some blood flow. It's just walk to the mailbox, move around. It's helpful for you. Respiratory movements, you breathing. Yeah, breathing's important, but as you breathe in, when you do that, you change the capacity of the size of your chest. As the pressure is going to fall, you're going to have that area is going to have pressure that's going to be lower, than the pressure that's below it, which is going to cause blood to leave the abdominal and move to the thoracic as it moves towards the heart. So by you breathing, it's going to have a big part of drawing that towards the heart, allowing for you to get back to. So the more respirations you have, the better off you're going to be. So you can see how this coins back to exercise being a big part of a healthy heart and of a healthy cardiovascular system. So vasoconstriction of veins under conditions of low blood flow and low blood pressure, the sympathetic reflex is going to cause contraction of the smooth muscles and the walls of the veins. We know that the veins are going to be the area where roughly 2/3 of our blood is going to be maintained. We can change the blood capacity depending on how much blood is leaving that area. Here showing muscular contraction, how blood is going to be moved up through this one-way valve, and it's going to be prevented from going back down by, let's say, our gastrocnemius that we're looking at here as blood moves toward the heart. The central venous pressure, all veins except those returning to the heart and lungs, drain into the right atrium. Pressure is going to be measured here at the right atrium. This is going to be the central venous pressure. Factors that are going to allow it to alter flow of blood into the right atrium. So it affects the pressure within the peripheral veins, and we know that if you have high pressure there, that blood is not going to move to it as easy. So a weakly beating heart increases the amount of that central venous pressure. So an increase in central venous pressure is going to cause blood to back up into the peripheral veins. As it does this, you're going to have peripheral edema. Because if you think about that way back slide that we talked about, the hydrostatic pressure on the arterial side, and how we got to the venous side is at roughly 16. If that 16 is a much higher number, we're going to have less of that fluid that's going to be returning, and we're going to have more of the fluid that's going to be pushed out of the vessel and staying out of the vessel. This is leading to peripheral edema, and then when I talked about pitting edema and that skin in our extremities. So increase in blood volume or venoconstriction increases blood flow to the right atrium, which increases the central venous pressure. All right, exercise and cardiovascular system. Exercise is good for the heart, but it has to be a part of regular life. So things that happen positively as a result of exercise. Your pumping efficiency is better, blood volume is better, hemoglobin concentration better, and you develop more mitochondria, which burn more oxygen, which means that you can break down carbohydrates at a faster rate. So people that are healthy tend to not be obese. Heart may increase to up to 40% larger. Your stroke volume as a result is going to be higher, and your heart rate and blood pressure is going to be lower. So for exercise to actually benefit the cardiovascular system, you need to run to 70 to 85% of your maximum heart rate. So this is roughly 220. This is a magical number. It's preset 220 minus your age. And you need to do this for 30 to 60 minutes, 3 to 4 times a week. So that's cardio. So me at 43, that's 220 minus 43, means I need to have a heart rate of 177, sustained for 30 to 60 minutes, 3 to 4 times a week. Definitely doable. And as a result of this, we're going to have these positive effects to the body, which is going to increase longevity. All right, guys, a lot about blood vessels. I look forward to seeing you guys soon.